A very good morning and welcome to the second joint meeting in 2024 of members of the Criminal Justice Committee, the Health and Social Care and Sport Committee and the Social Justice and Social Security Committee to consider the progress being made in implementing the recommendations of the Scottish Drug Deaths Task Force. So there's no apologies this morning, and our first item of business is to decide whether to take items 3 and 4 in private, which are to review today's evidence and to receive an update on the work of the People's Panel. Are we all agreed?
Yes.
Thank you. So our main item of business this morning is to take evidence on tackling drug deaths and drug harm. And I'm very pleased to welcome to the meeting Neil Gray, Cabinet Secretary for Health and Social Care, Mr Richard Foggo, Director of Population Health, and Ms Maggie Page, Unit Head of the Drug Strategy Unit at the Scottish Government. So warm welcome to you all, and I refer members to papers 1 and 2, and we're grateful to the Cabinet Secretary for providing some written evidence in advance. So can I invite the Cabinet Secretary to make some brief opening remarks?
Thank you very much indeed, Convener and colleagues. Good morning. I really appreciate the opportunity to answer your questions today. I would like to begin by wishing Christina McKelvey all the very best in her treatment, and we look forward to her return as Minister for Drugs and Alcohol Policy. We launched the National Mission to Reduce Drug-related Deaths in 2021. Since then, the Scottish Government and our partners have worked tirelessly to bring innovative and structural change to this complex emergency and remain fully committed to reducing drug deaths and harms. Soon we will see the opening of a safer drug consumption facility in Glasgow, the first such facility in the UK, which is backed by £2 million of investment from the Scottish Government. This landmark evidence-based service, co-designed with local people currently using substances, will help protect those most vulnerable from overdose and reduce harm. This, however, is just one of the programmes of work we have been taking forward, and I'd like to use this opportunity to outline the wider action we are taking to reduce harm and improve lives of people and communities impacted by drugs and alcohol. On the 31st of October, Audit Scotland published a report on drug and alcohol services which acknowledged that we have improved national leadership, made significant progress in tackling Scotland's long-standing issues with drugs and alcohol, notably through significant investment and innovative action in our national mission. This includes widening access to life-saving naloxone, expanding treatment capacity and increasing access to residential rehabilitation. However, despite all the progress, there is more to be done. The report specifically draws attention to work on local accountability, and we are stepping up our work with local leaders to strengthen accountability against both national and local outcomes. The report also highlighted the need for a whole systems approach and taking more preventative action. So let me assure colleagues of this Government's commitment in this area. Our response to the Drug Death Task Force recommendations has delivered progress. For example, the publication this September of the Mental Health and Substance Use Protocol and our work to implement the Workforce Action Plan published in December 2023. And our whole systems approach to prevention aligns with our wider vision for health and social care, a Scotland where people, including those with drug and alcohol dependencies, live longer, healthier and fulfilling lives. However, there is clearly still more to be done. The first years of the National Mission were about laying the foundations. We are now committed to building on those foundations, and while also responding to new threats and challenges such as the emergence of novel, stronger synthetic drugs which pose increased risk to our communities. Scotland's drug and alcohol deaths remain too high. I am absolutely clear on that point. And each death is a tragedy, a life lost too soon, and for those families will be felt dearest. However, we are driven by a steadfast belief in the necessity and possibility of change, and we remain fully committed to delivering on our commitments. So I look forward to the opportunity to provide fuller updates throughout this session. Thank you, Convener.
Thank you very much, Cabinet Secretary. And I think if I can just put on record also the committee's warm wishes to Christina McKelvey as well. So I wonder if I can open up questions, and I'd like to just ask the Cabinet Secretary for an update on drug checking pilot projects. So obviously we're aware that there have been a number of projects underway across Scotland. And so I'm just interested in an update on the expected timescales for decisions on the Home Office licence application process and the subsequent establishment of drug checking facilities in each of the pilot areas. So this is an area that we've looked at in the past in cross-committee sessions, and I would draw the Cabinet Secretary's attention to the comments of Kirsten Horsburgh, who I think at our last meeting, Kirsten Horsburgh from the Scottish Drugs Forum, very much welcomed the pilots, but was keen that there was progress made, particularly in timescales for establishment of the pilot. So be interested in an update on that.
Thanks, Convener. I don't have a specific timescale before me today that I can articulate. It's still subject of negotiation and discussion with the UK Government. The interaction that there is there with the Home Office is important for us to get round. I think we have had constructive discussions with the Home Office on this, and we certainly believe that the evidence points to this being another harm reduction measure that can make a difference in saving people's lives. It's linked to some of the work that's been done with radar in identifying where there are issues in the supply and giving people a greater understanding of what it is that they are purchasing and therefore using. And we're very keen. We've established the fact that we want to take forward these pilot sites in Aberdeen, in Dundee and Glasgow, and believe that alongside the safe consumption facility, this would help to take us forward on a harm reduction basis and to allow people the opportunity to have access to treatment as a result. Similar to the safer consumption facility, the signposting opportunities that are then available to help people towards recovery opportunities would be there. But predominantly this is about making sure that we're reducing harm.
Okay. I think the committee would welcome an update, perhaps, if that was possible, just on possible timescales.
I'd be happy to provide that, Convener.
Yeah, okay, thank you. Okay, there's a lot of interest in a lot of areas to cover, so I'm just going to open up and bring in Marie McNair and then Claire Haughey.
Thank you, Convener, and good morning, Cabinet Secretary and your officials. Obviously, with a new UK government just been elected there in July, I'm really quite interested to hear about any discussions that have taken place, with the new Labour government around their position on safer drug consumption facilities, drug testing, etc. And if you've not, do you have plans to do so in the future?
So the interactions that I've had with the new UK government, I've met with the new Health Secretary, Wes Streeting, pretty early on in his tenure. We're due to meet again soon, but this issue wasn't covered in those ministerial meetings, those ministerial discussions. I know that officials are, and I'll bring in Richard Foggo on the interactions that officials have had, but I think it's safe to say that I think there is a greater recognition in the new UK government of the importance of taking a harm reduction, public health approach to tackling this issue, reducing drug and alcohol-related deaths. And so I am hopeful of having a constructive relationship on that basis that would allow some of the areas that we want to see progress on, safer consumption facility being one. Clearly the issue that the convener raised around drug testing facilities would be another, but also the interaction of the legislation that is reserved will also be open for discussion, I hope. But I'll bring in Richard Foggo in terms of the discussions that have come thus far.
So, thank you so much. I met just last week with Sir Matthew Rycroft, the Permanent Secretary at the Home Office, just to form kind of initial relationships. Sir Matthew was in Glasgow specifically. We did hope potentially that he could visit Hunter Street and the new facility, but that wasn't quite going to be possible. So we covered at that meeting a range of issues, both in terms of of the overall strategic relationship. The UK government are establishing their health mission, so there's a wider set of issues here around social determinants which are really relevant in relation to our work on poverty. But much more specifically, we were able to offer Sir Matthew a clear briefing on the new facility to inquire after the drug testing. I mean, it was not appropriate at that stage to press on that. That's a matter for the Home Office to proceed, but we were able to cover the new safer drug consumption facility, the drug testing facilities, but also we had the opportunity to discuss through the task force on synthetics just the threat and the joint work we need to do collectively in relation to preparing and responding to those new threats. So that was a good constructive discussion at the highest level, so with the Permanent Secretary of the Home Office just in the last few days.
Thank you. If I can just come back on the sort of drug checking facilities, obviously, you know, 3 across Scotland. Is there any scope, obviously we know it's a pilot, but is there any scope to include additional ones if required?
I know there's interest in other areas, and you know, Edinburgh is obviously looking at this closely. But this is a pilot, and you know, so you start from a smaller place, and then if it's successful based on the test and learn process, you can build up from there. But if it is successful, I would expect this to be looking at a wider participation than just Aberdeen, Dundee and Glasgow, because this is an issue that, you know, those particular cities have particular challenges, but this is an issue that is facing all communities across Scotland.
Thank you.
Thank you. So I'll bring in Claire Hohey and then Sharon Dowie.
Thank you, Convener, and good morning, Cabinet Secretary, and good morning to your officials. Before I begin, I'll put on record my register of interest. I hold a bank nurse contract with Great Glasgow and Clyde NHS. Thank you for the update that you provided in your letter to committee about the stigma action plan and the ongoing work that's happening to address and challenge stigma. Could you maybe give us a bit more detail about that work and perhaps some of the timescales behind implementing that plan?
I'll bring Maggie Page in this area in a second. I think this is an area where, in discussions with family members that have been impacted by drug dependency and drug-related deaths, both those that are currently experiencing a family member with a drug dependency and those that have lost a loved one, they tell me that this is one of the areas that the National Mission has been of the greatest importance and made the biggest strides. The shift in regards to stigma and allowing people the space and opportunity to feel confident about accessing services, both for themselves and for their family members, they tell me, has been incredibly important. And that I felt that particularly keenly when I visited the service in Dumbarton, and also the private session that the First Minister and I had at the Travelling Cabinet in Ayr last week. The family members believe that the reduction in stigma is having a major impact on people feeling able to come forward. And that's why taking a public health approach as opposed to a justice approach to this issue is so important, and why keeping people in their communities, supporting them with some of the issues that are underlying their drug or indeed alcohol dependency, as Richard set out, you know, the clear correlation that is there with poverty is so important. But I'll bring Maggie in terms of the timescales, your specific direct question, Ms Hockey, so that can be addressed. That'll come on automatically.
Oh, sorry. Thanks. Yeah, so stigma is a cross-cutting priority for the National Mission, so it really does cut across all that we do, and it shouldn't sort of be seen in isolation as a plan in and of itself, but as much wider than that. So we've already invested over £3 million in making sure people with lived and living experience are genuinely at the heart of everything that we do. And the action plan, which was published in January 2023, is now being delivered alongside the National Collaboratives work, which is due to be published later this year. So a change team has already been recruited, and that's operating to make sure that this work is done in a co-production, with a co-production approach to implement a national programme. So the change team has met on a think, 2, possibly 3 occasions already, and that's taking that work forward. In addition to that, our Workforce Development Action Plan also is a really key pillar of that stigma work, because stigma within the workforce are the challenges that people face accessing services, not just drug and alcohol services, but wider care and public services, is a really, really important pillar of that. And it really it's important to see that the work in and around with this other work that's happening as well.
You'll be aware that the 3 committees commissioned a People's Panel, which met last month. And some of the panel members were interested in the role that the media plays in reinforcing stereotypes. So I'd be interested to hear what other work alongside the Stigma Action Plan is being carried out to look at that particular issue, which may in itself be a barrier to people accessing treatment or accessing help.
I think, Convener, Ms Hockey touches on an important issue where we all have agency in this respect, in the language that we use and the terminology that we use, and the recognition of this of a drug or an alcohol dependency being a health issue. I think there is leadership clearly that government can show in that regard, and we are trying to do so. But I think there is a role and a responsibility on those that report the news to be cognizant of not just the people who have a drug or an alcohol dependency, but their family members as well, and ensuring that the language that we use to describe these issues it does not then create greater barriers or maintain barriers to people feeling that they're able to access treatment. And that's the stigma issue. So some of the stereotypes and the language that is used, that has traditionally been used in this area, we need to move on from. And certainly in terms of the language that we adopt and how we approach this, that's clear, and we're making progress there, I believe, as a Parliament as well. But I think you're right that we all have a role to play here, including our colleagues in the media.
Thank you. Thank you, Convener.
Thank you very much. Sharon Dowie, followed by Annie Wells.
Thank you. Good morning. I wanted to ask you some questions on Audit Scotland's Alcohol and Drug Services report that was published recently. So, first of all, do you accept all the recommendations that are in the report? And could you give us an update on any progress that's been made on the recommendations?
So we're considering the recommendations carefully. I think there is a lot in there that demonstrates the progress that has been made already. And some of the recommendations are such as on local leadership and providing greater transparency there are areas that we are already developing work upon. So we welcome the report. In terms of each individual recommendation, we are considering our direct response to that. It was 31st of October that it was published. But we take seriously all of the commentary that comes forward from Audit Scotland in general, but particularly in this area. We'll consider all the recommendations carefully and respond in due course.
Considering them just now, you can't say that you can fully accept them then?
I think it's important that, as I set out, that there are recommendations there that we're already making progress on. I accept those areas of challenge, including around the local leadership that needs to be addressed. And I also welcome the report in general. It recognises, as I said in my opening statement, the national leadership that's been provided and the progress that is being made, and the interventions from the Drug Death Task Force progress that has been made. Will respond more formally in due course. I don't think you're going to see much challenge from us to the report, if I could put it that way, Convener. But we will obviously take seriously the recommendations that are in there.
In the report it says funding for tackling alcohol and drugs harm has more than doubled over the last 10 years. But it also mentions, however, ADPs have seen an 8% decrease in real terms of funding over the last 2 years. It also says that the Scottish Government has yet to undertake an evaluation of the costs and effectiveness of alcohol and drug services to determine if they're delivering value for money. So one of the things that's really important is that the funding is directed in the most effective way. So I've actually heard people describe the funding as spaghetti, because when you're trying to find help or a pathway, there's lots of groups out there that are trying to help people, but it can be confusing. So what is it the Scottish Government is actually doing to make sure that we are putting the funding in the right areas, because our drug and alcohol deaths are still far too high?
Yeah, I think Ms Dowie touches on a really important issue around the focus that's required, and the Audit Scotland report recognises that the national leadership and the consistency that is set out in terms of what we are expecting, and there is a recognition there that there is more work to be done to provide that consistency at a local level. Now, I think that is I spoke earlier about the foundations that have been put in place through the national mission, and this is now about building upon that and making sure that we're able to provide a consistency there. We have provided record levels of funding to ADPs, 112 million this year, over I think around £50 million each in terms of recurring funding and the national mission funding, obviously, we want to make sure that there is a consistency there, but I also recognise the local decision-making that is in place at ADP level, and we are going to be coming forward with further recommendations around providing a consistency of standard, and I'll bring Richard Foggo in to provide greater clarity on that point.
I think one of the key things here is that we can't see the services in isolation, and so one of the problems I think you're identifying there around the fragmentation requires us to look beyond the alcohol and drug services themselves. So I think one of the critical things we're trying to do in relation to the national mission is make those connections. So the Audit Scotland critical recommendation was about that wider whole system approach, and so in terms of the work we're doing locally around supporting and enabling public sector reform through the work we're doing in areas like Glasgow in particular, what we're actually doing is ensuring that alcohol and drug services is part of that consideration. So these are person-centred, rights-based services that are trying to get away from the stigma, from the fragmentation. So I suppose I absolutely recognise what Audit Scotland are coming from, where they're coming from. I think the recognition here, though, is you need to look at a wider context of services and not just the alcohol and drug services. I think we would accept that those are fragmented. So that through that work, we're supporting local partners with and investments, and through the Fairer Futures partnerships that we're developing, alcohol and drugs are absolutely central to that, because that's where you bring in the other services that are going to be so critical to this, whether that's the housing services or even broader into areas like transport. So just to assure the committees that we're looking at this in the round, and that's absolutely based on the insight that Audit Scotland have offered us in relation to that whole system approach to how we can support the alcohol and drug services. So just wanted to offer you that assurance that we are looking in broad terms at this.
It sounds good. There's a lot of kind of maybe buzzwords in there, but you've said that there's record amount of funding going into ADPs, but it still says in the report that it's seen an 8% decrease in real terms. So it's still putting a lot of money in, but we're not actually seeing any improvement in the figures of people that are actually losing their lives. So is there any specific action? So if you can sit and tell me, right, we've cut money to the ADPs, but we've now directed money to somewhere else, and that's why we're seeing a cut in ADP. So is there any specific actions that you can actually tell us that you're doing?
Yes, we're continuing to work with local systems on making sure that the money that is provided for ADPs are spent on the services that we would expect to be delivered. The doubling, as you recognise, Ms Dowie recognises and has been covered by Audit Scotland of ADP funding is there. There has been an increase in ADP funding, and that is provided both through the regular funding for alcohol and drug partnerships, but also through the increase that has been provided from the National Mission funding. Now, there is local decision-making at play here, and I don't want to cut across that nor disrespect the principle of local decision-making, which Ms Dowie will recognise. However, we are looking at how we can work with local systems, and I've got a wider interest here beyond this policy area around our health and social care partnerships on issues like social care as well, and making sure that there's a transparency around where the money is going so that services are tailored towards the people who need them. And that is as true for social care as it is, in this case, for people seeking alcohol and drug services.
Okay. The report also says about drug services, it lists 3 areas where progress has been particularly slow: publishing a mental health and substance use protocol, delivering a stigma action plan, and implementing a drugs and alcohol workforce action plan. Could you give us an update on the progress on those, and also the reasons for the slow progress? Because again, there's lots of money going into this, so in a lot of other areas would love to have the budget. So what progress are we actually making, and why is it so slow?
Yeah, so we are making progress. Maggie's already set out in terms of the stigma action plan. We've the workforce plan. I'll be corrected if I'm wrong. I believe this is being progressed at the end of this year. We are coming forward with more advice there, so there is work in train on all 3 areas, and I'd be happy to provide more information on that to the committee if it wasn't already in the written evidence that I provided previously.
Okay, thank you.
I wonder if, before I bring in Annie Wells, if I can just ask a quick supplementary on the issue of funding. So I'm a bit like a broken record when it comes to the issue of multi-year funding, and I know there are some sort of signals perhaps that the new UK government is slightly more willing to look at the option of multi-year funding, and we hear this a lot in all committees, probably the benefit coming from multi-year funding. And on the point that Mr Fogel made about whole systems working together, that's certainly relevant in the criminal justice space. So notwithstanding the point that the Cabinet Secretary made about local decision-making, is this something that the Government would welcome in this particular space, given, I suppose, the significant role that third sector, for example, plays in this area?
Absolutely, Convener. You hit on an incredibly important area, particularly for the community and voluntary sector. And yes, of course, we would, as a government, appreciate greater line of sight in terms of what budgets are going to look like, and that would help us in terms of our aspirations to provide multi-year funding settlements. And I recognise that those delivering statutory services would also benefit from that. We recognise that. We are making some progress there in this space. The funding that we provide to the Cora Foundation is an example of this, which is the route through which we are providing support for community and voluntary organisations to develop their services. But I'll bring Maggie in to develop this point.
Yep, thanks, Cabinet Secretary. Yes, so as the Cabinet Secretary mentioned, the Cora Foundation funding, which is £13 million a year, that is funded in recognition of this challenge, particularly for third sector and smaller third sector organisations. We made a decision so that the Cora Foundation would be multi-year funding. So a lot of those programmes are funded on a multi-year where appropriate. In addition, we provided written updates to the committee on the breakdown of our budget, and you'll see that of that £112.9 million that goes out to ADPs, about 56 million of that is a baseline allocation that goes via health boards, and that gives ADPs more security, and there's more dependence on that. And in recognition of that, and working with ADPs, and from their feedback, we're going to be baselining further funding from what comes from the drug and alcohol policy budget in order for them to be able to forward plan and to be able to recruit effectively. So we're very conscious of this challenge, and we've made a lot of steps to be able to provide that assurance, but we do operate within an annualised budget, so there's only, it's limited as to how much we can do.
That's very helpful. Thank you very much. OK, I'll bring in Annie Wells and then Pauline McNeill.
Thank you. Thank you, Convener. Good morning, Cabinet Secretary and your officials. I'm sure it will come as no surprise to the Cabinet Secretary to know that I'm going to ask about residential rehabilitation. And it was just really for an update on the number of beds we have available in Scotland just now and how many are actually in use at the moment, if you could provide that information.
I'll get Maggie to provide the exact number. The most recent funding increase we gave on residential rehab was 38 million in order to provide an increase of 140 beds. Public Health Scotland have estimated that the period for which we have data available in the last year is that 938 people have been able to be publicly funded through residential rehab, and they're confident that we can say with confidence that we are on track to meet the commitment that 1,000 publicly funded spaces will be available a year, and I think that's an important aspect of the wider investment that we're making, because there is no single route through which we can see people achieve recovery, because as Ms Wells will testify, for every person that has a drug or an alcohol dependency, there will be different circumstances at play for them, and it is important that we have a person-centred approach. So we need to make sure that we provide a balance and a range of harm reduction and treatment availability, so that we can give people the opportunity to find a way to recovery at a pace that suits them. And that includes the Cora Foundation support provisions that we're providing. But Maggie will be able to provide you the exact number of what we have, so I can provide that detail.
Okay, thank you. So we have, through our own investment in increasing capacity through 8 programmes, we're hoping to see an additional 140 beds, and that's towards our target of increasing number of beds by 50% to 650. I can't tell you exactly how many people are in services right now in beds. I always think it's strange to say beds, because it's not really how residential rehab works, but it's our unit of measurement. Because we don't have sort of live recording of that. However, we are commissioning analysts within Scottish Government to do another capacity audit. So we did one at the start, around the start of the national mission, as a sort of baseline, and that work is in progress now to see how much progress we've made. We do know from our own investment through the Rapid Capacity Fund that there's already 36 of those beds already operational, and a lot of other ones are due to come on stream as and when those projects finish. So taking all of that into account, and knowing that through our investment in supporting additional placements, which has created more demand, we know of other beds that have been created within services, and that mapping exercise will be able to give us a better understanding, and naturally we'll be sharing that as soon as it's finished.
Thanks very much for that, and that's really helpful. And obviously the target is, the ambition is 1,000 people will be publicly funded by 2026. Can I just ask for, I mean, I know we've spoken about 938 people have been publicly funded sort of this year, but do we think 1,000 is the right number, and how did we come to that figure of 1,000 people? Just
I'll be honest, I don't know why 1,000 was set as the target, and whether that is the right measure of, I don't think success is the right word, but I think Ms Wells understands where I'm coming from. So that target predates my involvement, so I don't know why 1,000 was set, but I think what we can demonstrate is the very clear progress that is being made in terms of the availability of residential rehab. The Audit Scotland recognised this as well in their report, to go back to Ms Dowie's line of questioning, and I think what we need to demonstrate across all areas is that we are making progress. We're reducing stigma, thereby allowing people the opportunity, breaking down the barriers for people to access support, as well as their families to receive support. And the progress that has been made in the access to residential rehabilitation beds is a sign of that progress. Again, as I say, I'll be honest, I don't know the reason behind the 1,000 being the target, and it will be for us all to judge whether that's the right measure. But I think the important part here is that there is demonstrable progress being made in the availability and the capacity in the system, and that's clear.
Can I ask one more small question? I think it would probably be quite useful if we could find out how many beds there were in each sort of a health board, or if we can split it up into sort of regions or something like that. I think that would be quite a useful tool for us to sort of know, because obviously we know that Glasgow, Dundee and things like that have more issues and impacted more. So I think it would be quite useful if we could get that information. I know you probably won't have it today, but if we could get it, that would be helpful.
I expect that this will form part of the audit work that Maggie referenced around what we're doing to check as to the availability of beds. And if we have further detail on locality or local authority level or health board level, then we'll certainly seek to provide that to the committee when that work is completed.
Thank you,
The committees, rather. Apologies.
Thanks, Convener. Thank you very much.
Thank you very much. Okay, Pauline McNeill and then Paul O'Kane.
Thank you very much. Good morning. Just following on from that line of questioning, Annie Wells did ask a central question, in my opinion, which is what is the demand? You know, it's acknowledged the progress that's been made, but we don't know what the demand is. So I think that's quite important to establish that. I mean, in your opinion, I mean, I know there's many ways to approach this, so be clear about that. But to what extent do you think that access to rehabilitation programmes, how central is it to tackling drug deaths, in your opinion?
I think it's one aspect, but as I say, from a getting it right from everyone perspective, which is central to not just this area of policy, but for the wider health and social care policy work that we take forward, we have to recognise that residential rehab isn't going to work for everyone. An abstinence route isn't going to be the right route. So it is a central part of our national mission, and I think that's demonstrated by the investment levels that we have made. But it is only one part. There are other elements there, including the investment into CORA that supports the community and voluntary elements.
I wanted to get a sense of how important you think that in all the things that we can do, how central it is, because I think at some point that question does need to be answered as to what is the demand. So I'm thinking here, I don't know how easy it is for drug users to access rehabilitation. I'm quite familiar with how difficult it is for those dependent on alcohol to access facilities. It's who do you call if you don't know? What is the pathway in? Are you satisfied that it's clear to... So people may not have families that support them either, or the families are just can't cope with it anymore, so they might be on their own. Are you clear about how easy it is to access that facility?
I think Ms McNeill again touches on a really important area on the awareness and the availability of services. But in this case around residential rehab, but this is where again I go back to my interaction with families who are currently experiencing another family member or a loved one that is experiencing a drug or alcohol dependency, or indeed who have lost a loved one to a drug or alcohol dependency, and their very clear view, and obviously I take from them their lived experience is prime here, that both the availability and the awareness of the routes in are improving. Now, that's not to say that it's all right. It's perfect, I think, but it is improving. Now, in terms of how residential rehab is accessed, there is obviously clinical assessments that are carried out by medical professionals as to the appropriateness of a particular person for a residential rehab place. I'm not going to interfere in a clinical decision-making process. That wouldn't be right, and I think Ms McNeill would recognise that. But making sure, but I do also think we need to make sure that we have a wider awareness amongst the health service and amongst community services as to the availability and if that particular route is not right for that person, what else might be. And I think, again, going back to Ms Dowie's questions around the clarity of what is available within communities and the role that alcohol and drug partnerships play in that, as well as some of the community organisations that help with signposting, that is the next stage that we need to make sure we have a very clear picture for people, so that if one particular route to a form of recovery isn't right for them, that there are other opportunities. They have an awareness that there are other opportunities there for them.
Thank you. Maybe some future date I'd like to come back on that point about the medical assessment, because if a person comes forward because they think they need the help, I think it's worthy of consideration if there are any blockages, because the medical assessment might reject somebody who's made such a big step. But maybe that's something that I'll come back at another date. Can I ask you, just to move on, about the question of men being twice as heavy users? I mean, given this is, I don't detect a lot of discussion about what approach we take, because we've got high numbers of men who are harming. How does that factor in the approach that you're taking to drug misuse and stopping drug deaths?
So I'll come back to the first point that Ms McNeill made, and then I'll address the second point of the gendered aspect here, and I'll bring Maggie in on both points. So the first, your first point, you know, I've experienced constituents who've come to me who are in exactly the situation that Ms McNeill has outlined, where they believe that it's right for them that they go to residential rehab, and there are clinical decisions that are made that make it more challenging. And I think this goes on to some of the work that we're looking to do to provide that clarity of, and the guidance is there around people that are presenting with mental health and substance dependency issues at the same time. And I'm very clear that we must support people to tackle both of those issues concurrently. They are driving one another. The substance dependency is driving the mental health issue, as is the mental health issue driving the substance dependency. So we need to be absolutely clear. I certainly believe this, that we need to support people on both aspects. And I'd be more than happy to return to Ms McNeill's points there. In terms of the gendered access, the gendered aspects to this, Ms McNeill again is absolutely right. The figures are absolutely clear in terms of the level of drug deaths amongst men, and indeed the prevalence of poverty and the correlation between people living in poverty and the impact that has. We have been, and this is where I'll bring Maggie in, we have been developing work around how we can target men to ensure that they are understanding of the support that is available. And again, this comes back to the destigmatising landscape being so important, on talking about men's interaction with health services. And, you know, both Mr Sweeney and I are currently participating in Movember, because we need to have a greater awareness and provide a greater level of comfort for people that interacting with health services, regardless of how uncomfortable it is to talk about. Chris Hoy again has demonstrated the importance of doing this over the last couple of weeks. It is just as important in the prostate cancer situation as it is here in terms of the drivers of drug dependency amongst men and the mental health aspects there. And so I think that I'll bring in Maggie in terms of the specific action that we've been taking in that area and the work that's developing here.
Thank you. So, yeah, what we know from the drug deaths data is around 2/3 of deaths are males and 1/3 female. But what we've seen if you're taking the longer term trend, is that that's gone from being roughly around a quarter female and 3/4 male to now about 2/3. So we've seen a disproportionate increase in drug deaths among women compared to men, but men still dominate. And that does mean that men dominate services as well. And we've done a lot of work looking at the needs of women, and also through that looking at that gendered approach to what both sexes need. And that's been really enlightening in actually understanding that there are different drivers and there's different needs and real different challenges that both sexes face. So that work has, I think, been really relevant for both, although a lot of that work has been around looking at the needs of women. It's actually making that distinction between the two.
I think maybe Bob Doris, do you want to come in with a follow-up question on that?
Just very briefly, Convener. Apologies for my delay in attending the committee. I thought Polly McNeill was really interrogating a really important line of questioning. It's that pathway in to residential rehab, and I think the Cabinet Secretary mentioned two aspects to that. The idea of what is or is not clinically appropriate, but also back on to, I think, Annie Wells's point about availability and access. What data does government or service hold about the numbers of individuals presenting and requesting rehab, and where that's determined not to be clinically appropriate? I know that some individuals would dispute whether that's accurate or not. That's the world we live in. I think that's reasonable to say. And where it's a lack of access to service. Because there's two reasons why someone won't get a rehab bed, and I don't like using the word bed. One is deemed not clinically appropriate, and one is the resource is not there. Is that mapped out? Do we have statistics in relation to that?
Again, I'll bring Maggie in to develop on this. I think Mr Doris, developing the questioning, touches on an important consideration, and I'm not familiar as to whether I don't think we hold data in government on this, and whether individual ADPs or indeed health and social care partnerships hold this is a question to be answered. And I think, given the line of inquiry, I can absolutely see merit in looking at whether that is a further development that we could take forward in order to ensure that there is transparency there around both the availability but also clinical decision making. But I'll bring Maggie in because she may be able to provide greater detail here.
Yeah, thank you. So essentially our residential rehab programme has got three broad strands to it. One's about increasing the number of people going in, so funding placements. One's about improving capacity, increasing capacity. And the other really important one is around pathways, and that's pathways into residential rehab and also out again. And occasionally back in again. Some people do need to go more than once, and that, we need to recognise that. So there's a lot of investment and work happening around that in terms of, so we're supporting Healthcare Improvement Scotland to develop regional improvement hubs, so working with groups of ADPs about improving their pathways and improving their awareness. In terms of the data, we don't have stats, robust data on the number of people who've requested residential rehab, and when we start to unpick that question, I think it would be quite a difficult thing to measure in an accurate way. But through this sort of improvement approach, it's actually about working with clinicians and other service managers and things to think about residential rehab, and that, I think, has really contributed to the number of referrals and the number of supported places. We've also now had an additional placement fund which was launched earlier this year. That was $2 million, additional $2 million this year. So for those areas where they've already used their allocation of money for residential rehab, that's allowing them to apply into a national pot, essentially, to fund more places. And that's all part of that sort of improving that flow and that pathway. And then looking at the other side of that pathway as well, is that through and out of residential rehab, because that's a really, really important and potentially a dangerous time as well, to making sure people are actually, transitioning out of residential rehab safely. And just another point to make is that we launched the rehab.scot website, which lists all of the residential rehabs that are available and the types of services that they provide, because they're a very diverse group. I think there's around 20, I'll have to check exactly, different service providers, and they're really quite different. Some of them cater to specific groups, and obviously there's different geography, so that covers where things are, and we can send on the link again to that website.
other members will want to come in, and a follow-up supplementary question would tie up the committee's time. But I'm conscious that with like CAMHS referrals, for example, one of the things the government promised to do was to look at rejected CAMHS referrals and audit that to see how robust those decisions were. So I just leave that hanging there. I mean, because data is difficult to establish, is not a reason not to try and establish robust data and all of this. But I thought Maggie Page made a really interesting point about individuals needing residential rehab more than once, because living with addiction is a lifelong challenge and a lifelong success for many people as well, and that needing for more than once. Of course, when an individual leaves the rehab, they're not leaving their journey and their challenges. Is there any monitoring or auditing of the support service that exists for people when they leave rehab? Because, of course, that's only part of the picture.
To address Mr Doris's first point, Convener, I think he has touched upon an area that I think we need to consider if there is a route by which we can collect and have robust data that is publishable, and we'll consider whether there is more that could be done there. On the second point, I think Maggie's already addressed the fact that we do provide, there is support available out of the residential rehab picture, and making sure that people are supported throughout that journey, and that will shift between community organisations depending on that individual, through community organisations, through statutory services, general practitioners. There is a variety of different individuals and organisations that could and should be involved in that picture. So again, it's going to be difficult to audit a journey, because for everybody's journey it's going to be slightly different. But I take the point around whether there is more that could be done there, and that's what we'll take away and have a look at.
Thank you, Cabinet Secretary. Thank you, Convener.
Very much. I'll bring in Paul O'Kane, followed by Jeremy Balfour.
Thank you very much, Convener, and good morning to Cabinet Secretary and officials. This committee, I think, has been very interested in the progress of MAT standards, and indeed, I suppose, the cross-cutting nature of trying to implement those both in healthcare settings and beyond. So, obviously, in the latest data from Public Health Scotland, we have seen improved progress, which is, of course, welcome. But I would be keen to get the Cabinet Secretary's view on the targets that are there for MAT standards. So, obviously, full implementation in community and justice settings by April 25, and then sustainable across all settings by April 26. So I suppose to what extent he feels those targets are on track, and what work has been done to make sure that those targets are on track.
So this is an area of importance, similar to, and this forms part of the suite of investments that are being made and the interventions that are available to provide a person-centred approach to responding to a person's drug or alcohol dependency. We've made particularly good progress on MAT standards 1 to 5, and that is to commend alcohol and drug partnerships on the work that has been done there, as well as the other statutory services that Mr O'Kane references. 6 to 10 has been more challenging, and we've got more work to do there, and that's where the previous intervention of some of my predecessors on providing directions to alcohol and drug partnerships to meet with the targets and provide the investments in interventions to ensure the MAT standards are being met is important. Mr O'Kane references whether there is a confidence around the timescales, and I can't give a guarantee today that we're going to meet those, but I believe that good progress is being made, that's been referenced, and will continue to support ADPs as well as the statutory services that are involved to ensure that there is a recognition of the importance of meeting these, because for some people, residential rehab and abstinence is the right route. For others, having a medically assisted treatment pathway is what works best. And we need to recognise that when we're trying to get it right for everyone, that we are taking that person-centred approach. So I'll take Richard in here to provide more detail.
So, thanks very much. The area that we're working most systematically on, the area therefore with the most risk, is definitely the justice setting. So working with SBS around MAT standards in prisons, that is an area that is taking up a huge amount of collective work. I don't have any indication that we're not on track for that, but that's taking the most work. The pressure on the Scottish Prison Service at the moment across a range of issues is so profound that I was speaking to Theresa Medhurst, the Chief Executive, just very recently, and Ms Constance chairs a group of ministers, including health ministers, working systematically on that. And in fact, the last deep dive we had at that cross-ministerial group was on MAT standards in prisons, and we heard from frontline system leaders, governors in charge and others about the challenges. So I can just offer assurance, recognise that that's probably the one where I feel there's the biggest risk, and the one that we're working hardest to try and address to ensure we're on track, but absolutely recognise that with the pressure currently on the justice system, and in particular the prison service, that's an area that I would say that we should be collectively paying attention to over the next 18 months.
Okay. Thank you for those answers and indeed for the candour. I think that is helpful to the committee. Obviously, the Cabinet Secretary had outlined some of the progress that is being made and some of the interventions that have been taken by his predecessors, indeed directions and things like that. I'm concerned, the Scottish Drugs Forum recently evaluated current practice in relation to medication-assisted treatment, and their findings actually suggested that only 15% of the participants in the evaluation were aware of the MAT standards. And I think that has to be, concerning, because I think it goes to the heart of how are professionals and others in the partners that we require being aware of these, and how are those in receipt of services being aware of these. And we also heard that some of the other themes that we've discussed this morning around stigma and around waiting times and delays and getting the support you need in the right setting and be able to access that is something that users felt was difficult. So I'm just keen to understand, how is the Cabinet Secretary drilling into those issues and taking that sort of approach to look at them, because those figures are worrying?
I would absolutely concur with Mr O'Kane. That is a serious concern, and I repeat, the interventions that we have taken that are not taken lightly or often in terms of ministerial directions, but we have provided that to ADPs, and the expectation there that we expect not just the implementation but the greater awareness of the MAT standards. I think it's also important to recognise, again, when we're talking about getting it right for everyone, that this is particularly important for those with an opioid dependency. We know different parts of the country, well, across the country, cocaine use is prevalent and has been implicated in a rising number of drug-related deaths, and we don't currently have a medically medically assisted treatment pathway available there. So that's why it's important that we look at this in the round in terms of all of the interventions that are available. But I'm absolutely clear on the importance of us making continued progress on the MAT standards, because for a great many people that does help to save lives. It does reduce harm, and it gives them a pathway in order to seek recovery. So I don't want there to be left in any quibbling as to whether or not we have any commitment to that. We do, and I take very seriously the statistics that Mr O'Kane raises. I can see that Mr Fogel wants to come back in.
I fully recognise the potential tension between the SDF findings and absolutely take that seriously. I think one of the next steps for us is to look in particular, referring back to points made earlier, that we're about to release the Charter of Rights for people who use substances shortly. And I think what's going to be fundamental for us in reviewing the MAT standards going forward is precisely to bring those two perspectives together. So I think we can tell you probably a really good story about working through Health Improvement Scotland and others and Public Health Scotland about how the system and system leaders are being made aware of this, but I think there is a disconnect. So I think that work that we're doing from the bottom up with lived and living experience through the leadership of Professor Alan Miller and the National Collaborative, I would like to say from a policy perspective, over the next period, a fundamental priority for us is to bring those two agendas together, because I think there's a risk that the MAT standards approach is quite technical, I think Ms Dowie did accuse me, understandably, of buzzword bingo. I do understand that, and I want to avoid it. But there's a kind of professional language, and Matt Standards operates at that level. But what we're getting from the SDF is reality from the ground, that this feels a bit alienating. And I think the big challenge for us as policymakers next is to bring those two things together. Commend the work of the National Collaborative. That's where the bottom-up, the lived and living experience is coming from. And we have discussed in that forum specifically the question of how we can make MAT standards a more accessible, understandable approach for those who are experiencing the services, not just for the managers, who also need clarity about how those services are run. So offer your assurance, it's not today, I get that, but it's an absolute priority for us to bring those two things together, the Charter of Rights plus the MAT standards approach, and to review and refresh that over the next few months.
I still want to return to our scrutiny. Very grateful, Convener.
I bring in Jeremy Balfour. I wonder if I can pick up on the point that Mr Fogel made, just the helpful update with regard to the challenges around the prison population, and it is something that the Criminal Justice Committee and the wider Parliament is obviously interested in. And I'm aware that naloxone is now available within the prison estate for use, and I was just interested in a sort of more broad question around naloxone, if I can direct that to the Cabinet Secretary. I think the Cabinet Secretary gave a helpful update in September in response to a question in Chamber with regard to some of the work that was being done by the UK Government, and essentially to make naloxone more available. Is there any update on that that the Cabinet Secretary could provide?
The Convener's right that there is interaction here in terms of the legislation that governs our ability to see a naloxone programme rolled out, that there is an interaction there. I don't have a specific update in terms of the UK Government's latest thinking here, but I am certainly aware of the prevalence of the carrying of naloxone and the use of naloxone across not just statutory services, obviously Scottish Fire and Rescue Service, Police Scotland, the availability for those that are involved in alcohol and drug treatment and further afield, but also the take-home naloxone kits as well, which has been, I believe, over 30,000 take-home naloxone kits have been distributed. The police service have, I think the figure for the police service is 530 doses have been used, so we can confidently say that a substantial number of lives have been saved as a result of the naloxone programme, and that, for me, I absolutely commend all those within the public sector that are, whether it's Police Scotland, the Scottish Fire and Rescue Service, or others, health professionals and others, who are carrying naloxone and are helping to save lives as a result.
I mean, I think that the increase in the emergency naloxone administration, I interpret that in a positive way, as the Cabinet Secretary was referencing, in terms of the broader reach of this as an option. And I think the committee members would be interested in what, if any, update was available with regard to the UK Government's work on this. Thank you very much.
Alongside the other updates, I'd be happy to provide that if there is anything further to update in response to this committee session.
That would be really helpful. Thank you very much. Okay, I'll bring and then Paul Sweeney.
Thank you. Good morning, Cabinet Secretary. Good morning to your team. I wonder if you can just give us an update on the expected opening date of the Safe Drug Consumption facility in Glasgow. It was due to be open last month. Just wonder where we are now and the timescales behind it.
There have been delays. Mr Balfour will be aware. He's referenced the fact that it was due to be opened in October. The Glasgow Health and Social Care Partnership are working with those to try to see it operational as soon as possible, and I'm hopeful that we'll see that happen before the end of the year.
Thank you, Convener.
Thank you very much. I'll bring in Paul Sweeney.
Thank you, Convener, and thank the Cabinet Secretary and colleagues for their comments so far. Just wondered if the Cabinet Secretary had any insight directly about what the nature of the delays have been with NHS Assure in approving the facility at Hunter Street.
I thank Mr Sweeney for his question and indeed his long-standing interest in campaigning in this area. I'll defer to Maggie on this to make sure that I'm not speaking out of turn. NHS and Assure are involved. There have been delays on making sure that facility can be operational. But in terms of how much detail I can go into, I'll refer to Maggie.
Yep, thanks. And we can give full detail in writing as well, but my understanding is that there's water testing now happening, and that has to be done over a 3-week period. And so we're at that stage of, the final snagging, essentially, in those assurance processes.
Just in the point of the Lord Advocate's prosecution policy, the Lord Advocate stated an intent in September 2023 to publish that prosecution policy. Do you have any insight as to when that will actually be published?
That is a matter for the Lord Advocate, and she will determine when it's right and appropriate. And I don't have any further update in terms of her thinking there or in terms of the timescales that are involved. But that's going to be a question for the Lord Advocate.
It's certainly very timely to see the pilot getting underway, given that there's been a reported increase in street injection in Glasgow. One concern that I do have is the 12-hour gap in operation between 9 p.m. and 9 a.m. Does the Cabinet Secretary share that concern? Is there a view that there should be an effort to try and increase operating hours if that's deemed to be necessary by the Health and Social Care Partnership?
Obviously, this is a matter, as Mr Sweeney will understand, for the Health and Social Care Partnership to consider. And we already have a pretty lengthy opening period there. I recognise the concern that he expresses in terms of what happens between 9 p.m. and then 9 a.m. But this is a pilot. This is a test of change. This is an area for us to test and learn, and I would fully anticipate that the Health and Social Care Partnership will be looking at what the demand is and whether or not their availability could be increased depending on what that looks like. But that's a matter, but he'll understand that's a matter for them, for Health and Social Care Partnership to consider.
I had the opportunity last year to go and visit Copenhagen to see how their model operates, and was very struck by how sophisticated it is. One of the key aspects in doing that was to understand the interface between the overdose or safe for consumption facility, overdose prevention facility, and referral pathways into rehabilitation. There was certainly from the staff working there said they'd noted a significant increase in interest in accessing rehabilitation. Sometimes it's non-linear, people go into rehabilitation, come back into using the facility and vice versa. But one thing they did note was that it was in close proximity, so that it was a matter of minutes to walk to the residential rehabilitation facility. I've just checked the closest rehabilitation facilities in relation to Hunter Street, the Thistle Centre, as it's going to be known, is about 4.5 miles away. So the Phoenix Centre is the closest in Annie's Land. Does the Cabinet Secretary have a longer-term view that we should be trying to co-locate or at least bring these facilities into closer proximity where there are concentrations of street injection?
So I think Mr Sweeney makes a good point, and the work that we've been doing in supporting the Health and Social Care Partnership has been around ensuring that there is that signposting and support availability there, and those conversations can be had. I think Maggie has already referenced the different the varying landscape that there is within residential rehab around in Scotland around the practices, what was going to be right for people, and so what might be appropriate for somebody at the Phoenix Centre, Phoenix Features, for instance, might not be appropriate for some people, and so they may need to travel further afield. Now, that is something for us to consider as we are looking to increase the availability of residential rehab, that we try to make sure that that is available as close to home as possible, and that we have that variety of service available. But he makes a cogent point around having those as close as possible. Having said that, we are, in some cases with our residential rehab, reliant on others coming forward, particularly from the community voluntary sector, to deliver some of these services, and particularly on residential rehab. And so there is going to be further work required if we're going to have it done on a co-location basis.
Thanks very much. Does the Cabinet Secretary recognise certainly that the recruitment has been very positive. I think there's been over 700 applications for around 34 posts, I believe, in the centre, which is very encouraging. But certainly that is a significant overhead in terms of operating one facility that may present challenges when coming to scale such facilities. Has the Cabinet Secretary and colleagues considered how you create like a hub model with some outreach which might be less expensive to establish? So, for example, looking at Glasgow City Centre and the pattern of where discarded needles are seen to be clustered, there are elements in the East End around the Barrowlands, and then you have a cluster near George Square, a central station in the city centre. Might there be an opportunity to build the main base at Hunter Street and then have a series of sort of satellite facilities, perhaps even mobile facilities along the lines of the converted ambulance that the unofficial pilot utilised? Is there options to look at how we develop this pilot going forward? Is there scope for doing something like that to try and capture more people? Because we know people don't tend to travel very far from purchasing drugs to injecting them.
There's certainly scope, and this is a pilot. So, we are the Health and Social Care Partnership, alongside ourselves, are going to be looking at the success of the centre being set up as it is, but also what might be possible if we were to be exploring alternative or increased opportunities from it. So, the suggestion that Mr Sweeney makes around the work that Preeta Crikent did is potentially part of that, and I don't think I'm certainly not ruling any of that out, because what we're wanting to do is respond to what the evidence demonstrate works, and that's why it's so important that we have this pilot, that we demonstrate that it works, and if there are further innovations that can provide greater help and support, then of course both ourselves and would expect Health and Social Care Partnerships would be exploring that.
Finally, Cabinet Secretary, is there a proactive engagement plan for cross-government colleagues, local authorities and indeed UK government colleagues to see this facility in operation once it's established? Certainly I happened to meet Dame Diana Johnson recently, and she certainly expressed a keen interest as a Home Office Minister in coming to see it and was very open-minded about how it could be developed. Is there an active plan for the Scottish Government to invite colleagues to see the facility in operation once it's established?
I very much welcome that interaction. It's not something, again, I go back to the questions that I believe were led by Ms McNair around interaction with the UK ministers on a minister-to-minister level. Those conversations haven't happened, but I would very much welcome, and I believe the Health and Social Care Partnership, without wanting to speak for them, would welcome that as well. And I think the learning that comes from this, I would expect a great number of people to have an interest in looking at the success or otherwise of this pilot, because clearly we have in Scotland a particular and a greater drug-related death issue to contend with. But these, we've seen from the recent statistics elsewhere in the UK that there is a rising prevalence of drug-related deaths elsewhere in the UK. It's not on the same scale as what we are seeing here in Scotland, clearly, and I don't wish to diminish in any way the challenge that we have in Scotland. But I believe that there is and there should be an interest on a wider basis as to the success or otherwise of the pilot that we're seeing at Hunter Street.
We've got a few minutes left, and I'm going to bring in Sharon Dowie just for a final question.
Thank you. In my previous questions, the national mission had been mentioned, but the issue of an implementation gap between legislation, policy and strategy and what is being felt by people on the ground was raised at the last evidence session, and it's also been an area of interest for the People's Panel. So could you maybe advise us why you think there's a perceived implementation gap and what the Scottish Government are doing about it?
Clearly, we've got work to do to build on the foundations that have been put in place by the National Mission, and we are looking to provide systematic change to the availability of services, to the types of interventions that we are making, And I think we've demonstrated today in the lines of questioning the variety of areas of intervention that the government is supporting, from the implementation of the MAT standards to safer consumption facilities, to drug testing facilities, to residential rehab. There is a broad range of intervention at play, and that takes time to build up. So I recognise that there may be a feeling or a perception of a disconnect there, but I believe that we're making progress. And I can say that because of the interactions that I've had with families that are saying that progress is being made. And we've got more work to do, that's clear, and the perception that Ms Dowie narrates demonstrates that we've got more work to do, and we need to make sure that the change that we're looking to deliver is both demonstrable but also felt at local level and by individuals and their families. And that's certainly what our collective effort across government and in partnership with local authorities, with health and social care partnerships, with alcohol and drug partnerships, with the community and voluntary sector that have an involvement here, as well as the families and advocacy organisations. That's what we're all geared towards.
But interesting, as Mr Foggo had mentioned earlier on about me saying it was buzzword bingo. I don't think I've actually heard that phrase before, but I'm sure it's one that I'll probably use in the future. I think as a committee we're interested to see actions happening to ensure that we do end up having improved results. So it would be good to see that we don't just talk about strategies, but we actually see them getting implemented, and I would quite like to get more evidence on that. So, but thank you.
Thank you very much. And on that point, I'm going to bring this session to a close. Thank you very much, Cabinet Secretary and your officials. That's been a very interesting session this morning. And I am aware that some of the issues that we've covered this morning are of interest to the People's Panel, which we've been referencing throughout the session. So I hope this evidence session will inform some of their further deliberations during their final meeting, which will take place this weekend. So on that note, that completes the public part of our meeting, and we'll now move into private session. Thank you.